Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 41st virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I am a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Acute and Chronic Knee Pain, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on either the IBJI or NSYMCA websites. I am pleased to introduce Dr. Kevin Hayek, MD, an Illinois Bone and Joint Institute board-eligible orthopedic surgeon with fellowship training in arthroscopic surgery and sports medicine. Dr. Hayek is here to teach us about the symptoms, causes, and treatment options for one of the most common joint complaints, and probably the reason you're here with us tonight, knee pain. Acute pain is pain that occurs suddenly and can range from mild to severe. Acute pain goes away once your body heals from whatever caused the pain. Chronic pain, on the other hand, is pain that lasts for at least 3 months. It might be there all the time, or it may come and go. It too can range from mild to severe, and chronic pain can last long after you recover from an injury or illness. This evening, Dr. Hayek will help us understand why we have knee pain and what we can do about it. Dr. Hayek grew up here in Chicagoland and graduated from Georgetown University's medical school. He completed his residency at the University of Minnesota, where he obtained specialized training in orthopedic trauma and sports medicine. He then went on to complete a fellowship in arthroscopic surgery and sports medicine at the University of Chicago North Shore Orthopedic and Spine Institute. During his fellowship, Dr. Hayek provided medical coverage for the University of Chicago Maroons College Collegiate Athletics and the Concordia University of Chicago football team. Dr. Hayek specializes in arthroscopic surgery of the hip, shoulder, and knee, including ACL reconstruction, meniscal repair, hip labral repair, shoulder labral repair, complex rotator cuff repair, complex knee surgeries, cartilage restoration, and patellar instability. He also specializes in the reconstruction, easy for me to say, of the hip, knee, and shoulder joints, and performs anatomic and reverse total shoulder replacement based on patient needs, as well as anterior total hip replacement. Dr. Hayek emphasizes patient education and enjoys partnering with his patients to help them understand their diagnoses and treatment options so that together they can determine a care plan through shared decision-making. He relies on high-quality, evidence-based research to develop a customized approach to fit the needs and goals of each individual patient. Dr. Hayek values family and the character of the communities he grew up in, which brought him back to Illinois to serve the residents of the Northwest Side and beyond. Outside of his practice, he enjoys spending time with his growing family, recreating on Lake Michigan, me too, and providing medical coverage for local athletic events. During Dr. Hayek's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the question section on your screen, and I will receive them and relay them to Dr. Hayek immediately following his presentation. I do ask that you please keep your questions general, however, as Dr. Hayek will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Hayek via one of the options that's posted on the slide now and will again be listed on the slide shown during the Q&A portion at the end of his presentation. One last thing before I turn the evening over to Dr. Hayek. I invite you to mark your calendar for our next IBJI and YMCA Education Series program on Thursday, July 27th at 7 p.m. Dr. Michael Q will answer the question, what is regenerative medicine? Thank you again for joining us tonight, and thank you, Dr. Kevin Hayek, for your time and effort in putting together this program to help us learn more about the symptoms, causes, and treatment of both acute and chronic knee pain. Dr. Hayek, please take it from here.
I want to thank Karen and the North Suburban YMCA for having me. It's an honor to be here with everybody tonight. Hopefully I can provide some valuable information for you. I will say that the knee is one of the most common, if not the most common joint that I see people for in my practice. I do general orthopedics, as the long list of procedures may have suggested, but I have a special interest in the arthroscopic surgery, which is the minimally invasive surgery in the hip, knee, and shoulder joints. So, but let's get started. So I think there was a nice summary of what sort of acute and chronic pain, but we're going to highlight it again just to do some clarification. So I had 3 educational goals for everyone tonight. By the end of this talk, I'd like you to be able to define what's acute and what's chronic pain, and maybe kind of understand how your physicians might think about your pain a little bit too. That way, sometimes the communication can better facilitate what everyone's sort of goals are. Learn some of the common causes of both acute and chronic knee pain, and then know when you should consider seeking care, and learn maybe some of the initial treatments that you can start even before you see a physician. So acute pain, what is it? 3 general things to describe it would be something that starts suddenly, could be it. That could be an acute pain. If you had a pain that just you kind of woke up with, that could still be an acute pain, or it could be a pain that happened while you were doing working in the yard or working in the garden or doing a sporting activity. And it may or may not be the result of an injury. But in general, acute doesn't necessarily mean the severity, but it means that symptoms from a medical perspective have been going on for about 30 days or less. What about chronic pain? One thing I'll say about the acute pain is sometimes acute pains can resolve with conservative treatment, and we'll get into when you should think about seeking expert sort of care. Chronic pain, so symptoms that persist for more than 3 months, those are the ones that we'll consider to be chronic pain. But even though it's been 3 months, doesn't necessarily mean they're permanent. It doesn't necessarily mean that treatment has failed and there's no options. And it doesn't necessarily mean that someone's on pain medications or narcotic medications. There's somewhat of some stigma out there that chronic pain, means that there's no options or you might be on narcotics, and that's not necessarily true. It's more of the chronicity that sort of helps us define it. So let's talk about, some of the causes of acute pain. I'm going to just go through these a few quickly right now, but we'll look at some in depth. But remember, acute pain being less than 30 days duration could be the result of an obvious injury, or it could just be pain that started. Could be some of the things that it can be is tendon strains or of the muscle or the tendons. You could have ligament injuries. You could have exacerbation of underlying things like gout, crystalline arthropathies, things like that. You can have things that are kind of concerning like a septic arthritis, or you can have just tendinitis, which is sort of inflammation in some of the tissues. We're going to go through a few of these in more detail. So one of the first things I always like to do is talk about the anatomy of the knee, and there's different layers to it. We'll think about in your mind's eye is a great way to say it, and you're going to peel back the layers, below the skin. We have the skin and the subcutaneous tissue or the subcutaneous fat, which is the body's cushion. And then below that, you have the muscles and the tendons. And then the deepest layer would be like the bones and the cartilage. So if you look on the left, about the knee, the things that are pertinent, starting top to bottom would be the quadriceps muscle. And there's 4 individual muscle groups that are a part of it: the rectus femoris, the intermedius, the vastus lateralis, and the vastus medialis oblique. And they're connected to our patella, our kneecap. And then south of that, connected to our infrapatellar ligament or our patellar tendon. People like to debate whether it's a ligament or a tendon. You can call it whatever you want as long as you know where it goes. And then, that's connected to your shin bone or your tibia and makes the extension of your knee. Things that are also, in play are your IT band, which goes from your hip to your knee, common source of tendinitis. On your medial side, you have your medial hamstrings that wrap around. And that's sort of the muscular layer. Deep to that, in the knee itself, the joint, I would say, so that's below the muscles, below the ligamentous capsular, the lining of the joint that makes it a closed space, you have 2 major types of cartilage. So there's 2 types of cartilage in the knee. And the cartilage doesn't have any mineral. So it doesn't have any calcium in it. And so We'll talk about it when I show you some x-rays in a minute, but that doesn't show up on an x-ray. It shows up as a space. And so generally speaking, at a joint, space is good. The first type is called the articular cartilage, which is the covering on the end of the bone. It's sort of like the tread on the tire is what I liken to it. It's the bearing surface. And when we're young and when it's pristine, it's very smooth. It looks like fresh snow, and it's very slippery, like fresh ice. It allows us to have the pain-free sort of gliding motion in all of our joints. And we have it, from our fingers to our hip and to our shoulders and pretty much everywhere you could think of it. In the knee, the other type of cartilage is called the meniscus. And the meniscus are these sort of C-shaped or horseshoe-shaped discs that are the shock absorbers. And they sit in between the thigh bone, the femur, and the shin bone, the tibia, and they cushion the bones so that they don't bang into each other so hard. And they kind of accommodate the fact that the bottom of the thigh bone is kind of rounded and the top of the shin bone is kind of flat. And they increase the surface area in that same way to increase the contact area, decreasing the pressure. There's 4 sort of main ligaments in this deep layer. You have your medial collateral ligament, your lateral collateral ligament, and your cruciate ligaments. So your collateral ligaments, which are on the sides, they help with the bending stability. They keep you from getting too knock-kneed or too bow-legged. Inside the center of the knee, you have your cruciate ligaments. There's your anterior cruciate ligament, which almost everybody universally knows as the ACL. And then you have your posterior cruciate ligament. And these help with sort of rotational stability, and they keep the bones aligned when there's directional changes in the knee. So let's jump into some of the causes. So one of the most common causes, which probably everybody has experienced at some point, is a muscle or a tendon strain. And what it is exactly is, and you can have them anywhere in your lower extremity, or so around your knee is pretty common. You could have them in your calf, you could have them in your thigh, in your medial hamstrings. Anywhere you have muscle and tendon, you can have a strain. And what it is sort of like a partial stretch or tearing. And it can happen different ways. Sometimes you sort of overextend it and you stretch those muscle fibers, or you can have a partial tear where the muscle bulk or the muscle belly sort of turns into the tendon. So in your sort of the functional units, you have the muscle belly, which actually contracts and sort of does the work power. And then you have the tendon, which is sort of like the connecting or the rope, and then that connects to the bones to basically cause movement through all the joints. So you can have it either in the muscle belly, you can have it in the musculotendinous junction where that tendon and the muscle meet. And it's usually a stretch or a partial tear. And so these are pretty amenable to resolution on their own with some what I call TLC. And we'll talk about that in a second, things you can do. And the body will sort of repair these. Sometimes it doesn't really have the ability to sort of pull everything back together, but it can sort of thicken things up or hypertrophy or make other areas sort of more functional adjacent that are still intact. So people, often feel this as they say they pull the muscle. The common symptoms are, you usually with this can remember an injury. You said, oh, yep, I was lifting something, or, I went to get up from the ground or went to get out of bed and I just felt that I pulled something. I wasn't quite sure on the feet and I know exactly what I did. Usually people do feel some amount of pain. There's some soreness, and then you might have some mild or even moderate swelling in the area. Sometimes there's a little bit of overlying warmth or even mild redness, that suggests that there is an underlying injury. And what can happen is you can have a little bit of that stretch, and with the stretch, you sometimes get a little bit of localized bleeding at the site, which can be good because it brings nutrients and inflammatory cells that cause sort of the healing response. And like I said, usually you'll improve or resolve with rest, or other sort of conservative interventions that we'll talk about in a little bit. Here's something that I often get questions about, especially from my younger or my high school athletes, and they always ask, do I really need to stretch to prevent injury? I don't think it does anything. And I will say it's a very sort of controversial thing in the literature about stretching, whether or not that it can prevent any kind of knee injury. And this, because of how common these injuries are, they've studied sort of it a lot in different large sort of settings and areas in the country. And for preventing any kind of injury, it's very mixed as whether or not stretching can help. But for maybe muscle strains, stretching and maybe after more than before might stretching before and after can be beneficial. But in general, we might think that the cooling down is more helpful with all injuries, but before it may help with strains. And so what I tell people is, you always want to warm up with activity. It's not necessarily that you're going to get injured, but whatever you're doing, if you're doing an athletic activity, if you're playing paddle tennis or pickleball, or you're going to shoot some hoops or whatever it is, you kind of want to know how your body is responding. You kind of want to know if you're having a good day, or a bad day, or how good things are, because I think then you know how your body is going to perform. And maybe in that sense, you might save yourself from an injury that could have been preventable. But big point of contention, especially among physical therapists, athletic trainers, and people in our musculoskeletal field about whether or not it is helpful or not. So let's talk about meniscus tears. So this was on our list. So remember, the meniscus is that shock absorber. Some people call it the brake pad of the knee because it cushions. And it's these sort of C-shaped cartilage discs, or horseshoe-shaped. Doesn't show up on the x-ray just like the articular cartilage or the tread on the tire because it doesn't have any mineral. And it can be a cause of acute pain because you can get it from, you can get an injury to it during a tear. You can have different ways to tear it. In our younger populations, they may tear it sort of more traumatically in a sporting injury, playing soccer or playing basketball or something like that. But you could have an acute meniscus tear also in the setting of more chronic issues. Like we'll talk about osteoarthritis in a bit. But in the setting of osteoarthritis, you can still have an acute pain from a meniscal tear. People often think about the symptoms of pain at the joint line. And so what the joint line is that's sort of the space where the femur and the tibia meet and sort of where the hinging of the knee happens. And so usually it can be kind of localized to that area. Often, if it's your medial meniscus, which is the more common one to see cause symptoms, it's posterior and sort of medial. And people will often say, I feel like something is clicking or catching or even locking. It's kind of like having a hangnail if you have a meniscus tear, because as your knee needs to bend, the meniscus kind of needs to get out of the way. And if there's a hangnail, as it bends and you're putting force through the knee, that sort of flap or that tear of the meniscus might sort of catch and then get caught. So the other symptoms would be swelling, because as the body notices that there's irritation in the knee, it knows how to do one thing. It says there's irritation, there's friction, make more lubricant. And so it tells the cells that line the walls of the knee to make more fluid because it thinks that's what you need. Unfortunately, that sort of causes this pressure effect that then causes more pain, more stiffness, more difficulty bending the knee. And so that's one of the reasons why you can lose the range of motion or feel like it's tough to get it fully straight or tough to get it fully flexed. So on the bottom right-hand screen there, that is a picture from surgery, from one of my surgeries, arthroscopic picture. So that upper part is the bottom end of the thigh bone or the femoral condyle, so the weight-bearing portion. The bottom or the flat portion underneath is the top of the tibia or the shin bone. And then the thing that's kind of in between that looks like that C or that horseshoe is the meniscus. And this is how perfect cartilage and perfect meniscus should look. It should look like fresh snow, very smooth. You shouldn't see any ridges. You shouldn't see any fraying, any long grass. And, this is true of what it looks like, when we're 18 and we're 20 and maybe even 30. Over time, though, you can get fraying and wear. And as we'll talk about in a minute, the cartilage can wear out over our life. And we'll talk about the nature of osteoarthritis, but let me show you some more pictures. So again, on the right-hand side of your screen, perfect meniscus over there. The cartilage looks very good. And then if you look on the lower left-hand side, you can see that's what a tear looks like. And that's kind of like an oblique tear or a radial tear through the body of the posterior horn of the meniscus, or the back of the meniscus. The cartilage up top is fine. The articular cartilage up top on the condyle, femoral condyle is fine, or the bottom of the femur is fine. Cartilage on the bottom, on the top of the tibia is fine, but you have that sort of tear going in there. So there's different things that we do for this, and we'll talk about some of the conservative things. So you don't necessarily always have to jump to surgery with a meniscus tear. If you're a younger person and there's a big displaced tear, we do think about maybe fixing it right away. In the middle age and in the setting of arthritis, sometimes we treat it conservatively. So that's where the exact patient scenario kind of plays in. And I tell everybody, everybody's different. We come up with a plan together for what's right, for you. But in some cases with a tear, like you might see on the bottom left over there, in this one is probably most amenable because it's a smaller tear. It's toward the sort of inside of the meniscus. That's not as amenable to healing because the blood flow comes from the outside in. This one might be one that in somebody in their 30s or 40s or 50s that you would do a partial resection or a partial meniscectomy to sort of bring it back to a stable margin so it couldn't re-tear or cause problems. In somebody who's 18, you might try to fix this because they got a lot of life ahead of them. And we want to protect as much of that cushion as you can to prevent the cartilage on the ends of the bone from seeing too much pressure and potentially wearing out earlier than you'd like to see. Ligament injury. So this one's great. So like I said, everybody's probably heard of the anterior cruciate ligament, or ACL. It's one of the four main ligaments. So you have the ACL, the PCL, the MCL, and the LCL. The cruciates are in the center of the knee. You can see it on the right over there. And the collaterals are on the sides. And the collaterals do that stability to make sure you don't get knock-kneed or too bow-legged. And the ACL and the PCL help with the rotational stability and helps making sure that the tibia doesn't slide too far forward or too far back when you're doing activity. And you can tear all of these injuries or all of these ligaments depending on what you're doing. Like I said, it depends on the force that's taken. So if it's a cutting or pivoting, usually that gets your ACL, like if you were playing soccer or basketball or something like that, or potentially even like paddle tennis or pickleball. The posterior cruciate ligament is kind of uncommon. That's more of a high energy injury. We tend to see that in people who've been in motor vehicle accidents, dirt bike accidents, ATVing, things like that. It's just not quite as common in sort of the sporting or everyday scenario, but you could still injure it. So that's usually more in the realm of high energy injuries. The medial collateral ligament, like I said, that's the one on the inside of the knee that does bending stability so you don't get too knock-kneed. That one is common. So if you have what's called a valgus stress, or you have a knock-kneed stress put on your knee, you can stretch that one and get an MCL sprain. So that one is pretty common. The good news about that one is if you have an MCL sprain, that's usually always non-surgical. And the lateral collateral complex, or the LCO, the lateral ligament, this one's a little more tricky. Hopefully you don't injure that one. Often that gets people who are skiing or sometimes in the setting of an ACL injury, but that one's just a little bit more tricky to recover from and to repair. So hopefully you haven't had that experience. Like I said, many ways you can injure it: twisting injuries, bending injuries. It kind of just depends on the force that overstretches that ligament. What are the symptoms? So often people know that they had an acute kind of injury. So pain, swelling, or an effusion. So usually if you tear one of these ligaments, the knee will swell up because you'll tear it there's blood vessels that go to the ligaments. You'll get a little bit of bleeding, and then that will make the knee kind of swell. You might also feel like the knee is unstable or you can't put weight on it. I would say, one of the things is if the knee, if you had an injury doing an athletic activity and the knee swells up, that's usually a good reason to get checked out. We'll talk more about that in a second. Or another thing is sometimes people have these injuries and they think they're okay, and they're like, it wasn't too bad. But if you have the inability to do the kind of activities you were doing before, that can often be a sign that you might have a ligament instability in a knee. Pictures up at the top right there. The one on the left, that is an anterior cruciate ligament that looks very healthy. You can kind of see it in the drawing below in the center of the knee there. So it has these sort of fibers that go in line with the ligament, and it's sort of ribbon shaped. So it's narrow in the middle, wider at where it inserts on the shin bone, on the tibia, and wider where it starts as origin up on the inside of the femur. The picture on the right there, that's what a torn ACL looks like. As you can see, it's sort of got those fraying pieces. It doesn't look like the fibers are under the tension, and you don't see it going all the way up into the wall of the femur there. The ACLs, the ACL reconstruction is something that's commonly done. The interesting thing is, you don't need it. It's considered elective because you don't need an ACL just to walk around. But if you have cutting and pivoting activities or things like that, or you want to get back to those, then we think about doing a reconstruction of it. And we generally now have to build a new one. There are some evolving techniques to repair it in young people like kids who have sort of that regenerative potential. But in general, in younger people too, we think about repairing, reconstructing or repairing it because we want to prevent subsequent sort of instability or shifting episodes in the knee that can cause damage to that cartilage that covers the ends of the bone, that is the tread on the tire. So crystalline arthropathy, here's another good one. Some of you probably have unfortunately had to experience this one. The two most common ones are called gout and pseudo-gout. So, these are basically compounds that are chemicals that are in our bloodstream and get filtered out by the kidneys. And unfortunately, sometimes they build up and they can end up in the tissue fluid and in the fluid of the synovial tissue, which is the lubricant of the joint. And so sometimes in that setting, they can actually precipitate out, just like a chemistry reaction, like in high school or college chemistry, you'd make something precipitate out. That's kind of what happens with gout and pseudo-gout. And the crystals become like little pieces of glass or little knives, and they just create this stabbing feeling. So unfortunately, you have the pressure from the fluid on the knee, and then you have this sort of stabbing feeling. So it's really sort of a miserable thing. People characterize it as the pain, the warmth, the swelling, the difficulty bending. The treatment, is often to do an arthrocentesis or drain some of the fluid off. Sometimes we send it to the lab to have them look at it like they're looking at it on this picture under special refringence of light to see the crystals. And then often the treatment can be a corticosteroid or a steroid injection into the knee, or systemic kind of steroids to help the acute inflammation calm down. This one's sort of one of the miserable ones. I see this, almost every week in the clinic, someone who has a gout or pseudo-gout. There's some misconceptions about gout. Gout is uric acid. So it's a normal compound that we have in the body. It gets filtered out by the kidney, but sometimes it builds up. And sometimes they often say it's related to diet, which is sort of true. The classic teaching in the medical textbooks is if you had a fatty meal or a heavy meat meal or aged cheeses, you'd be at risk. Or if you are over consuming alcohol, then you can get a flare of gout. And that's true, but often there's a heavy genetic component to it. Like there's some people who do all those things and never get gout, and there are some people who do none of those things and they just get stuck with it anyways. Pseudo-gout, The reason why it's very different, totally different compound, but it feels the same, which is why it gets the name pseudogout. So pseudogout, or some people also call it chondrocalcinosis, calcium pyrophosphate. We often, that one, the calcium we can end up seeing on the x-ray. So on the bottom left down there, you can see this is one thing that'll tip me off in clinic if I see this sort of pattern where I'm seeing this line sort of in between the bone where the meniscus should be or where the cartilage is. You know, that makes me think, oh, they might have chondrocalcinosis or pseudogout going on. Bursitis, so prepatellar bursitis. The bursa, so we have bursas in our elbow with lots of places in our bodies, but the most common one that we think about, you know, is over our kneecaps and elbows. And what a bursa is sort of like sliding tissue. It's almost like tissue paper that's kind of wet, that slides, and the goal of it is to create some kind of layer in between a bony prominence and the skin, so that the skin doesn't get irritated as it moves over it. And so in our knees and in our elbows, where we have a lot of range of motion and the skin has to stretch and slide, we find these bursas. So they are kind of like a closed space, and they can get inflamed though, or irritated, and you can get a bursitis, which is basically the body senses that even though the bursa is supposed to be the sliding tissue, that it gets more irritated. And what does the body do when it gets irritated? It says, make more fluid, make more lubricant. That's what I know how to do to solve this kind of problem. And so often you'll see swelling over the patella or kneecap, or in the infrapatellar region, right below it, over the patellar tendon. And you know, the diagram over there nicely kind of shows you what's happening where that fluid is building up in that area. Now you can just have what's called an aseptic or a non-infected bursitis, which is usually an irritation or overuse. In some cases, you can have something called an infected bursitis or a septic bursitis, which looks nothing sort of like that picture. You would see things would be red, hot, swollen, sort of look like a cellulitis, and be sort of even more acutely painful to touch. And so what can sometimes happen into these bursas is some of the sort of natural skin flora that we have on our skin. There's normal things on our skin that's just a healthy part of our life. Things like staph can sort of get pushed down into a little bit deeper layer, and then sometimes it can get into the bursa, and I'll find this area of fluid and it says, I'm just going to set up camp right here and cause a problem. So the treatment, you know, if it's an infection, is usually antibiotics and sometimes surgery. You know, it depends sort of how severe it is. Usually you want to get the fluid out, because if you have a fluid collection, which is called an abscess or something like that, the antibiotics that you're giving can't usually get to it, because the antibiotics can only go wherever there's blood vessels. And if there's a big collection of fluid, there's no blood vessels in there. So for all these acute problems, you know, the initial treatments that you can even start before you see an orthopedic provider or any kind of medical provider may help you get relief from some of the symptoms. But relative rest, so this is often goes by the name RICE, but relative rest, not necessarily like full bed rest, because sometimes that makes things worse. Usually inactivity breeds sort of stiffness, makes more inactivity, makes more stiffness, makes more pain. But relative rest, so taking it easy or taking a break from the sort of most intense activities. Ice, so ice combats that inflammation, combats that generation of sort of more fluid. Gentle compression, so things like ACE wraps or knee sleeves can be very helpful at relieving pain and relieving the swelling. Elevation, so keeping the limb up, you know, above the level of the heart, so that any of the swollen sort of fluid can get reabsorbed by the body and get returned to the rest of the system. And then things like Tylenol and anti-inflammatories. Tylenol is very good for sort of the pain response. Anti-inflammatories include things like NSAIDs, which are over the counter, and then also steroids, which are, you know, sometimes prescribed by doctors, either as pills, or sometimes we give anti-inflammatory corticosteroid or cortisone injections. The thing I'll say about NSAIDs, so these are the non-steroidal anti-inflammatories. Most of you will know them as Motrin, Advil, ibuprofen, Aleve. There's also diclofenac or Voltaren, those kind of things. These ones are, so Tylenol is metabolized by the liver. It's generally very safe. It's so safe that they even give it to folks who have liver problems or who are awaiting a liver transplant for pain. NSAIDs, on the other hand, so NSAIDs, the nonsteroidals, are metabolized by the kidneys. These ones can cause a little bit more trouble if you take them in the highest doses for the longest periods of time. So if you have issues with your kidney, then we sort of use caution with those. If you have also a history of gastrointestinal issues such as GERD, or if you've had an ulcer in your stomach or your gastrointestinal tract, also use a lot of caution because they can contribute to an ulcer forming. So if you've had any of those problems, you generally, and you're taking it, consistently or taking it more than once in a blue moon, you should consult with your primary doc to see if it's advisable, since they are going to know sort of all of your medications and sort of your long-term labs and things like that. And the other time when you should maybe use caution with these NSAIDs is if you're on blood thinners like warfarin, Coumadin, Eliquis, apixaban, Xarelto, heparin, Lovenox, those kind of things. It can sort of contribute to making the blood more thin in conjunction with those. But they are really very powerful medications. They are sort of the mainstay of the orthopedic treatments for inflammation. And so, I'm sure almost all of you have had to call upon them at some point. So when to seek care after an injury? If you have trouble bearing weight, I would say you should definitely think about seeking care. And if the symptoms don't resolve with those kind of initial treatments that we talked about, those would be 2 reasons to seek care a little bit earlier. But if you can't put weight down, then we start to worry that it might be something more serious, or you could even have a fracture in there, which we didn't talk about. And then, like I said, if they don't respond to initial treatments, then you should definitely seek care. When it's kind of more of, try some treatments and then it's more of a judgment, you say, well, if the pain's severe and it didn't get improved, then, think about seeking care. If you're having trouble fully straightening your knee, that can be a sign that maybe you've had a ligament injury or a meniscus injury and something's blocking you from fully straightening it. If after an injury you've developed painful clicking, catching, or locking, if you have redness or pain in the knee and you have systemic symptoms or things like fevers or chills or malaise, or you just don't feel well or you feel like you're sick, in those settings you should definitely seek care. And then if anything kind of gets worse, if you have swelling that's worsening, funny feelings in the leg, or the leg's not working, the muscles aren't working like they should, that's a reason too. And then I always tell people, always, if you have concerns, if you're not sure, that's why we're here. If they didn't want you to see a doctor, then we wouldn't exist. That's my break to remind me that we're going to start the chronic pain. So causes of chronic pain, the common ones that you may have heard of: arthritis, including osteoarthritis, rheumatoid arthritis, lupus, psoriatic arthritis. These ones are very common. And what arthritis is it's basically pain in the joint, but more specifically, it's the wearing out of the cartilage in the joint. We'll talk about some of those more specifically, including osteoarthritis and rheumatoid. A lot of the other ones below, tendinitis, bursitis, crystalline arthropathies, meniscus and cartilage injuries, they can sort of straddle this line where they can be acute and they could also be chronic. One question that might come up that I'll kind of answer now is, well, what about this time period between the 30 days and 3 months? You kind of left 2 months in there where we don't have a label for it. We call that subacute. That's what I call the treatment phase. So we'll talk about that more, but that's where I say is like, hopefully in that point where you're having symptoms for more than a month, you're getting some treatment. And so subacute pain or treatment phase. So osteoarthritis, this is the wearing out of the joint. This is the sort of bone-on-bone arthritis. This is a mechanical problem. Over our lifetime, the actual articular cartilage that covers the ends of the bone starts to wear out. It becomes more brittle, it becomes somewhat desiccated, and it's prone to sort of thinning and wearing down. And the body senses that irritation. It starts this process where it says, motion is hurting the knee. I want you to do less motion. So it starts to make it swell. It starts to grow these bone spurs. And the idea is that the bone spurs are trying to limit your motion so that you don't irritate or wear down the cartilage anymore. And that's where those sort of osteophytes or the bone spurs come from. The body's kind of trying to auto fuse or fuse the knee sort of together because it thinks that's what it needs to do to limit pain. The osteoarthritis, mainly is the wear of the articular cartilage, but also as part of it, you get degenerative tearing or fraying of the meniscus. So that's why meniscus can be an acute or chronic problem. There's a genetic and there's an environmental predisposition. So some people are just more prone to getting osteoarthritis, but also there's environmental issues, like if you've had an injury, like you tore your ACL or you tore your meniscus in the past, or you had a sort of a divot or a pothole in your cartilage that covers the end of the bone from an injury, you're more likely to have osteoarthritis down the road just because of that injury. And so it's one of these things where there's some people where it's hard to change and others where it's a combination of what's happened in life. The environmental causes are kind of variable. Like I said, there's the injuries that you have. There's also the fact that it is a bearing, and it is subject to the stresses of the body. And so if you're of increased body mass index or increased weight, that's harder on the joint. It's harder on the cartilage and may cause it to wear out faster. Some chronic medical conditions also predispose to it, just because the overall health in the rest of your body, is not good. And you can't, if you can't keep the foundation of the body going, then, sometimes it's like if the foundation of the house is bad or things are collapsing, you're not worrying about the lawn or the planters or things like that. And then diet and health kind of matter too. Good diet and good health bring the nutrients, preserve the cartilage. Rheumatoid arthritis. So rheumatoid arthritis is an autoimmune condition. It's an inflammatory condition where the body's own sort of defense system is hypermobilized and it's sort of attacking its own tissues. So this is mainly an inflammatory problem. It's a problem of inflammation. It's a problem of the body having too good defenses. And it becomes a mechanical problem when the cartilage starts to wear out. In the rheumatoid arthritis, and one thing about osteoarthritis is that sometimes we'll see wear more on one side than the other. So in this individual, they've got more wear on the inside of their knee. In rheumatoid arthritis, it tends to wear out more symmetrically in both the femorotibial, so between the thigh bone and shin bone, and also in the patellofemoral or in the kneecap joint too. And so you see a more symmetric wear. You tend to see less large osteophytes, and you tend to see, like this one, a little bit of the osteopenia or the thinning sort of the bone. It just doesn't look as dense. So, the medical treatments for the management of the acute and chronic problems, oral medications. So you have the over-the-counters, like we talked about. Then there's prescription anti-inflammatory. So there's prescription sort of NSAIDs like meloxicam or Mobic, and diclofenac or Voltaren. And those are good, anti-inflammatories. Other prescription medications that you might have prescribed would be muscle relaxers or spasm relievers. These are not narcotics. The common ones are called Flexeril, methocarbamol, Robaxin, or tizanidine, and they can provide a lot of help. Often we can give them for the knee. Most have heard of them sort of in the back. That's very common if you've had back issues to get prescribed one of these. Topical medications such as Voltaren or diclofenac gel, I think, is great. It's over the counter now. For many years it was prescription, but diclofenac or Voltaren can help a lot. The knee is an area where it's sort of superficial in a lot of people, so you can rub it on, put it on there, and it can get to the site. You might also get physical therapy. So people always ask me is, well, is physical therapy going to work for a knee problem? Well, it depends on what it is. Obviously, if there's something surgical and you need surgical, you need that first. Sometimes we send people to therapy before surgery to help restore motion so that they can have a better outcome and that their recovery can even start before the surgery. For the chronic conditions, the way I think of it is if you have something like arthritis, what physical therapy will do, well, one, it'll improve your mechanics. It'll improve your kinematics and how your body positioning is, and it'll help your body work more efficiently. The way I think of it is if you imagine you have a rope and it's hanging over the side of a dock or hanging over the side of a table or something like that, and there's a heavy weight on it. If you're very strong, you can kind of flip that rope up and it kind of glides. If the weight's very heavy or you're not very strong, you're going to drag that rope across the edge of the table, across the dock, and it's going to get frayed. It's going to see friction, it's going to create heat, and it's not going to be as good for the rope. And that's kind of like in a knee, if your muscles are strong, like your quadriceps and your hamstring, your knee will glide more because they'll work more efficiently, and it'll put less stress on the actual joint, on the actual cartilage surfaces. And so in that way, I think physical therapy is extremely variable, extremely helpful. Hopefully it's not too variable. Hopefully we get consistent therapy. Injection therapy. So there's a couple of different things that you can inject, and you could give a whole talk on the injection therapies. The three main ones that are injected into the knee are called, number one, corticosteroid or steroid, anti-inflammatory. It's like taking a fire extinguisher and putting on the flame. Same kind of idea as taking a steroid by mouth, but if we inject it into the knee, we're putting it local. You don't have to metabolize it through your body. Hopefully takes down the acute problem, tells the body to stop making so much fluid, stop sending so much inflammatory cells, makes the pain get better. Sometimes the cause of the pain, if it's something like arthritis or rheumatoid arthritis or osteoarthritis, can flare up again, like the coals of the fire could still be there. Or even if you have something like a meniscus tear, it might come back, but it can give you some relief, and it can allow some of the other things to work. In some cases, for some things, if you've had an acute injury or strain and you just can't reset the cycle, it can be like pressing the reset button. So there are some people I give a cortisone injection to, and I don't see them for a long time, or years sometimes. Everybody's a little bit different. It depends on the nature of what's going on. Second type is called viscosupplementation or gel injections. These are the hyaluronic acid. They used to be called rooster comb in the old days. Pretty much, they're called rooster comb because they used to make it from rooster comb biologic tissue to re-inject. What it is hyaluronic, but now it's all synthetic. What it is hyaluronic acid, and it's the building blocks of cartilage. So they don't exactly 100% know how it works, but they think, the scientists and things like that, and the researchers, think that by injecting this viscous tissue, it's sort of like good lubricant that lubricates without creating too much pressure or space. And then also you're bathing the cartilage in one of its building blocks, so it might make the environment a little happier and slow the breakdown of it. And you can have, it's shown to sort of be non-inferior to cortisone. In some cases, it works better for other people than others. I usually try cortisone first because I think that'll get you some quicker sort of relief. The gel is a little bit more variable, but some people do get very good relief from it. In general, for any of these things, we don't necessarily make a schedule for saying you have to get another injection. In general, I think 2 to 3 times a year, it's reasonable to get an injection up to that much if you're getting relief. Most insurers, commercial insurers, and Medicare will cover a gel or a viscosupplementation injection up to twice a year, but every 6 months, basically. The third type is called biologic injections. So these are sort of injections of your own sort of substance back into you. They are a little bit more experimental. In general, they are not currently covered by most insurers, so there can be an out-of-pocket cost for them. The two most common ones that have reasonable data for them would be PRP, or platelet-rich plasma, which is taking your whole blood from basically a peripheral stick. They spin it down they spin it down with a centrifuge 2 times and get this area of the blood that's fractionated. It's the platelet-rich segment, and then it can be re-injected. And so it combats inflammation and may stimulate healing, and it may combat inflammation in a way that's different than sort of what steroids can do. And it also has some ability to have healing potential. The other one that's has reasonable data for is called bone marrow aspirate. This one is where you actually take blood from inside the bone. So it's a little bit more invasive because you have to sort of perforate the wall or use a special device to go inside the bone and then to take blood out. You get some progenitor cells. So some people call this stem cells. I think that's a little bit disingenuous to say they're not necessarily embryonic or pluripotent stem cells that can become any kind of cell, but they do have some healing potential. Again, it's a little more invasive. I would never sort of recommend this as a first sort of treatment, but these 2 are the ones that have reasonable data. Other things that are experimental, like umbilical cord stem cells, things like that, there's not really good data for that in the orthopedic literature. And then bracing activity modifications. So some braces, whether it's a knee sleeve or a knee brace with a hinge, those can be very helpful, too, depending on what the condition is. So surgical treatments. So there's 2, main ones. You're either sort of, for me, you're either in the category of arthroscopic surgery or you're in the category of joint replacement surgery. And so, joint replacement surgery, where you're replacing or resurfacing the joints with metal and plastic, is where the whole kind of joint is globally worn out, and none of these concerted treatments have worked. And usually you've had multiple months or if not years of these treatments, trying to get it working. And in that setting where the whole joint is worn out, you have end-stage arthritis, like I showed you in those pictures, bone-on-bone changes. That's where you're talking about getting a joint replacement. Arthroscopic surgery in that setting where you're sort of like bone on bone and worn out is not going to give you as much, relief. The times where you get the arthroscopic surgeries are if you have sort of a focal injury, like you have a localized meniscus tear, or you have a focal ligament injury, like your ACL, or one of the other ones I talked about, or you have a single sort of little focal pothole in the cartilage that covers the ends of the bone. So in that case, you can have just a localized area of you could call it arthritis if you want, but we often call it chondromalacia or an osteochondral or a chondral injury. In those settings, there's sort of treatments arthroscopic. What arthroscopic surgery is a minimally invasive surgery done through smaller incisions. And there's special instruments that go into the knee and cameras so that we can look inside the knee without having to look, with our own eyes. And that was what some of those pictures were. And so you can look all around the knee, and with special instruments, you can rebuild ligaments, repair meniscus, do procedures to help sort of stimulate cartilage if you've had a focal injury, things like that. So that will conclude what I wanted to talk about. Hopefully we'll get to some questions in a second, but just going over our educational goals, I'd like to define the acute and chronic pain. So hopefully you know that. Acute, less than 30 days. Chronic, greater than 3 months. Common causes, acute and chronic knee pain, they somewhat overlap. You can have things of both. The arthritis, those often are in the chronic knee pain category. And then knowing when you should seek care for either of these things. So I would say if you can't bear weight, or if the conservative treatments didn't initially work, then you should go seek care. Or if the pain's really bad, or if you're feeling like your whole body's sick, or a couple of the other ones that I said. So with that, I think we'll open it up to take some questions. Again, thanks so much for having me. Hopefully this was, very informational.
All right. Thank you very much, Dr. Hayek. That was really informational. And I think that I love the way you explained so many different things. So thank you so much for that. I love the way you explained physical therapy. I've never heard it explained that way, about strengthening and the rope and everything. I thought it was great. So thank you. I'm sure everybody else did too. Okay, so Sandra asks, how long is recovery from knee replacement surgery?
That's a good question. So I would say it depends on what you're looking to do. So in general, the recovery, most people are pretty happy walking around comfortably around 6 weeks, even better at 3 months. Sometimes you're needing assisted device for the first 6 weeks, like a cane or a walker. It can take a year, though, to get as good as you're going to be. And so the rate at which you improve is very fast in the beginning, and then it kind of tapers off, but people do still keep improving all the way through, we think, the first year. Nowadays, most people, are having the surgery as either an outpatient surgery where they go home the same day, or they stay maybe one night in the hospital. And so we've learned a lot, especially with the pandemic, which forced us to make a lot of changes in how we were doing the recovery. And we actually get people kind of into PT earlier by having the PTs come to the houses now, sort of on the day after surgery and things like that. But it's certainly, I would say, if you're planning a recovery, you want to lay kind of low for the first 3 months. Like, you're not planning any big trips. You're probably, not going to be up for having any other kind of procedure or something like that. It's a good 3 months before it's activities as usual.
Great, thank you very much. All right, Cheryl asks, why do I still have pain in my knee 1 year after total knee replacement?
It's a good question. There's a lot of different possibilities, and that's one of those things where you want to get sort of checked out and see what's going on. Their knees are a little bit more, I don't know if I want to say tricky, but they're a little bit more, we'll say tricky. I would say with a hip replacement, in general, as long as you don't have an infection or you didn't have a dislocation where the socket and the ball came apart, almost universally those people do well, and have minimal pain afterwards. With knee replacements, in some cases, and this has been reported in our literature, it could be maybe up to 20% of people are better, but they still might have some pain. I wouldn't lose hope that you're gonna have pain forever. But if you're still having pain, that's worth sort of getting checked out, either with the doc who saw you before or with somebody else.
Okay, great, thank you. And you mentioned hip replacement. Camille asks, how does a hip injury radiate to the knee and cause pain there?
That's a good question. I would just say it does. It has to do kind of with the arrangement of the nerves and where the pain sensory and the sensation, the sensory sort of organs or the sensory zones in the brain are located. And so sometimes the cables sort of go along the whole play, like the nerves exit your spine and go past your hip and go down to your knee. And they're sending messages up to your brain. And the spot where you're supposed to interpret, the pain in your knee and the pain in your hip is right next door to each other. So sometimes the brain just gets confused. It's not anything that's wrong with you. It just says something's wrong. I'm not exactly sure with where it is, but it's somewhere along this time. This is somewhere along this sort of power line going down your leg. And so you can have it other way. Often you have hip, but most often it's hip pain that's radiated down sort of to the knee. So the classic teaching is, if you have a pain, you see somebody for knee pain and the x-ray doesn't look that bad, you should probably get a hip x-ray. Make sure they don't have hip arthritis.
Got it. Okay, thank you. That was really helpful. Okay, now we're going to move over a little bit to meniscal tears. Is it unusual to have a second meniscus tear in the same knee years apart?
Not horribly unusual. The overall rate of healing of a meniscus tear, so it depends on if it's repaired or not, but you can re-tear it. You can re-tear the meniscus whether or not you had a repair, whether or not you had, you just treated it conservatively, or whether or not you had a partial meniscectomy or a partial cleanup. So either are true. In general, if a meniscus gets repaired, the overall rate of healing is about 80%. In the setting of having a ligament reconstruction like an ACL, it's higher. It might be in the 90s, okay. But you could certainly re-tear it, whether or not you had surgery and whether or not you had it repaired or whether or not you had a partial meniscectomy. We
Gotcha.
like, when we're doing the surgeries and if we're doing a partial meniscectomy, we try to leave as much cushion as we can. That's good. So you kind of ellipse it out to a stable margin if you're doing a partial meniscectomy. And if you do a repair, it is possible to re-tear where you had it before or in a different spot.
Got it. Okay. Is someone more prone, someone who has a meniscal tear, is their menisci more prone to meniscal tears?
I would say you're more prone to having injury in the setting of injury. Yeah.
Got it.
Yeah.
Okay.
You're
Okay.
more prone
Thank you.
to tear if you've had a tear sort of repaired. Yeah.
Got it. Okay. Thank you. All right. And now on to osteoarthritis. Why does osteoarthritis cause so many points of short-lived acute pain on an inconsistent but frequent basis? This person gets pain in all sorts of places around the knee, but the same activities on a day-to-day basis may or may not cause pain.
Yeah, it's very interesting. You sometimes don't know what you do. The pain is usually generated when the body starts to build that swelling. And so sometimes you could do the exact same thing and the body interprets it differently, a different way. It says, oh, that's too much for today. That's too much pressure or too much stress. I got to make the fluid. I think I need to make more lubricant. And so sometimes it's other factors too. It's about the overall health of the body or what's going on or its ability to make fluid. And but usually when you're getting those acute flares, often it's from the swelling and it's creating pressure, and that pressure is creating sort of the pain.
Okay, got it. Thank you. What is your view of naproxen versus Voltaren or Mobic?
I think that with any of those NSAIDs, people tell me that different ones work for them. So unfortunately, it's kind of like trial and error. If you say that one's not working for you, then we try another one. And, some people tell me Aleve works for them, or some people say only ibuprofen. Some people will say Mobic's great or diclofenac. So it's a little bit of trial and error. I don't have one that I 100% could say works for everybody.
That makes sense. We're all different, right? So,
yeah.
Okay, great. Can cortisone injections in the knee cause headaches?
I don't know that that's a common, symptom, but it's possible. Like if you've had a couple cortisone injections, it could be. The cortisone is a steroid, and the steroids can affect the bodies in a lot of different ways. And so if you've had a cortisone or you've had multiple cortisone injections and you gotten a headache after, it's possible. That might be something to ask the primary physician about if it's impacting some other health domain or some other comorbidity or medical problem that you have that it's exacerbating. But it is possible, not common to hear it, but I would never tell you never.
Got it. Okay. We have gone past our time. We had a couple more questions, but it's 8:05 and I don't want to keep you later than you had anticipated. So
why don't we do two more if you want to do two more?
Two more. Okay, excellent. All right, that's great. Yes, we're happy to do two more. Okay, let me see. I wanted to ask you, but we ran out of time, so I'll do this one. Has there been any development and or progress in developing a synthetic meniscus that can be inserted to replace a damaged or missing meniscus?
It's a good question. It is not a durable type procedure, so I would not say that it's become mainstream anywhere. There are places where it's done experimentally. There's providers in California who do it, and you can find them on the internet. My concern with it is that it's any of these synthetic things, I worry about them breaking down. It's not a metal or a plastic. It has to be sort of like a silicone or things like that. Or something that is flexible or has some compliance to it. And those type of compounds, we've had trouble with them breaking down. They've used those type of sort of more flexible compounds in some joint replacements that are done in feet and fingers, feet and hands and fingers and toes and things like that. But after a while, they do break down and can cause some issues. So it's experimental at this point. There are people who are interested in researching it, but they haven't quite figured out the right material science. It's not being done mainstream.
Do you think they'll get there eventually?
I don't know. It's a hard problem. It's one of the reasons why, you know, we still replace the joints themselves with metal and plastic, and because we haven't, you know, come further than that at this point.
Gotcha. Okay. And you mentioned how PRP is not a covered service. The person asks, how about bone marrow aspirate? And then you also mentioned about how there isn't a lot of data yet. And do you think that these types of injections are sort of maybe the future of helping, you know, joints that are struggling?
Yeah, there's a lot of people who are researching this. They have an interest because it's something that is your own tissue.
Right.
And so there's a lot of research going on right now. I think they're going to flesh it out. I do hope at some point that insurance would cover PRP. We're just not there at this point. Some of the best places for the PRP, you know, where the evidence is best is in things like in the elbow for like tennis elbow or for rotator cuff, but it's still evolving. And so for that reason, you know, the commercial insurers and Medicare have chosen not, you know, to go with it. The bone marrow aspirate also is not currently covered by insurance.
Okay. Okay, great. Thank you so much again, Dr. Hayek. Very informational. I love that so many people stayed on even through the questions. That's always exciting. That shows us that people are really interested. So thank you everyone for joining us tonight. And Dr. Kevin Hayek, thank you very, very much for all the great information and for taking the time to answer so many questions. If you have questions, you can reach Dr. Hayek by the information that's on the screen. And if you haven't jotted it down yet, get your phone out, take a picture of it so that you can have it, so that you can reach out to Dr. Hayek. Again, Dr. Hayek, thank you so much for your time. Thanks for coming back. I hope everything is okay with the situation that caused you to not be able to join us a couple of months ago. We're really glad that you took the time to come back again.
Thanks so much. Family's doing very well. Really appreciate that. Pleasure being here. Hopefully it was very informational for everybody. Have a wonderful evening.
Thanks again. Have a great night.